So I'm thrilled to have two speakers joining us today, both calling in from the Duke University School of Medicine to share about their research as it pertains to the older adult population, a particularly special population that has much to gain from smoking cessation. So our first, or actually she'll be our second speaker, is Dana Rubenstein. Dana is an MD candidate with an anticipated graduation in May of 2025, so very soon. Dana recently completed a Master's of Health Sciences in Clinical Research with a thesis that focused on cannabis and tobacco and pain. And so we'll have to have you back, Dana, to hear about your findings because I know this group's very interested in cannabis and tobacco as well. Dana is quite accomplished already and truly a rising star. She has 30 peer-reviewed publications, and these include publications, of course, focused on cannabis and tobacco, rural tobacco use, and of course, the older adult population, which she'll be talking about today. She has numerous awards, including 4 in the year of 2024 alone. These include awards from the National Institute on Drug Abuse, Diversity Scholars Travel Award, as well as the International Association for the Study of Pain, World Congress Travel Award. And she's also applied for and earned Tobacco Regulatory Science Pilot Grant that seeks to predict response to a nicotine product standard in medical and psychiatric priority populations. So quite accomplished. Dana, thank you for joining us today. And our first speaker is Dr. Joe McClernon. Joe is a clinical psychologist and a professor in the Department of Psychiatry and Behavioral Sciences at Duke. And he's also the associate director of Duke CTSI. Joe has nearly 200 publications focused on increasing our understanding of tobacco use, developing new and more effective interventions for treating nicotine dependence, and a good body of work on informing the FDA's regulation of tobacco products. He's been NIH funded for numerous years and has a current R01 focused on product standards for tobacco products among dual e-cigarette and combusted cigarette users. For those who are familiar with the scenic study led by Dr. Dorothy Hatsukami, which is a multi-site study that looked at the impact of a reduced nicotine standard in cigarettes, Joe has been a long-term PI for his site that has led to the recruitment and enrollment of the participants. One of the things that stands out about Joe's CV to me is his remarkable track record of mentoring. He has mentored many K awardees. He served as a mentor to Dana as well, and he recently received a career mentoring award in clinical research at Duke University. So we have some very accomplished speakers today, and I'm just so thrilled to have them join us. If you have questions during their talks today, either pop them in the chat or you can wait till the end during our Q&A. So with that, Joe, I'll have you take it over.
Awesome. Great. Thank you so much, Dana, for those amazing introductions and for inviting us. I understand that we'll be on Zoom this year, but I appreciate you already inviting us back in person next year during state fair time. So we're already really looking forward to that. Thank you. It really is a special to give a presentation to this audience at the University of Minnesota. I've been, as Dana said, I've been collaborating with folks there for over 10 years now, almost 15 years. And I can easily say some of the most fruitful, impactful, but also really enjoyable collaborations of my career. So it's really special to be here. As Dana said, we'll be talking today about older adults and tobacco use, particularly in the context of a changing tobacco product landscape. Before I start, I want to make it clear that Dana and I do not have any conflicts of interest to disclose, and all of our work that we're presenting today is NIH funded. The work that we're going to be presenting today is really represents a working group and an emerging coalition or consortium of folks who are interested in studying this question of older adults and tobacco use. And this includes my colleague and co-presenter today, Dana Rubenstein, medical student at Duke. It includes Rachel Demlinger at Wake Forest, Jenny Ross, who's a health communications expert at Boston University, and Dana Carroll, who you all know is an amazing epidemiologist there at the University of Minnesota. The goals of our presentation today are really threefold. We want to review the epidemiology of cigarette and e-cigarette use among older adults in the U.S. We want to talk about the continuum of risk related to nicotine and tobacco products, and then describe harm perceptions and normative beliefs that are unique to older adults that may inhibit smoking cessation, and also potentially inhibit their switching to lower risk products like e-cigarettes. So I don't have to spend a lot of time on background with this audience. It's 2024, and somehow cigarette smoking is still the leading cause of death and disability in the U.S., with over 400,000 lives lost to tobacco-related disease every single year. It's responsible for 30% of all cancers, and older adults who smoke exhibit excess morbidity compared to non-smoking peers, including increased risk of dementia, lung and other cancers, and cardiovascular disease. So when we look at the overall prevalence of smoking, in some ways it's unfortunate that this graph starts in 2019, but it's also remarkable to say that in 2023, towards the end of 2023, we were looking at the prevalence of smoking most or all days, right around 10% for the US population. This represents a pretty sizable decrease even from 4 years earlier. And there's a lot to be excited about in seeing this. This represents a real change in smoking behavior in the US, and we anticipate it portends a decrease in tobacco-related disease. But not everyone is benefiting in the same way or seeing the same kinds of trends that we see in the general population. And in fact, when we look at the prevalence of smoking behavior across age groups, we see that really, and this is nothing to be disappointed about, we see that the bulk of the decrease in the prevalence of smoking over the last 5 years is really due to a decrease in smoking rates among young adults, so people who are 18 to 34-year-olds. I've been watching this graph on the NHIS website for a long time, and a year ago I was going to say it's just a matter of time before smoking rates are lower in young adults than they are among people 65 and older. And at the end of 2023, that happened. These 95% confidence intervals are just barely touching one another. And this is really due to the decrease in smoking rates among 18 to 34-year-olds, but also to a real lack of change in the smoking rates among people who are 65 and older. And I also want you to look at the last few years among 50 to 64-year-olds and 35 to 49-year-olds. We're not seeing the same kinds of decreases that we see in 18 to 34-year-olds. Now, this is certainly happening in the United States. I always like to also look at the state where I live and the states where I'm presenting data. So if we look at North Carolina, we see the same trend. This is daily smoking prevalence by age. And what you can see in the brown line is over 10 plus years, really no change in the smoking rate among individuals 65 and older. Compare that to 18 to 24-year-olds here. And if we look at the great state of Minnesota, we see a strikingly similar pattern. Again, no change really in the last 10 plus years among those 65 years and older. A real sizable decrease in smoking rates among 18 to 24-year-olds. But here again, look at that orange line, 55 to 64-year-olds. Not really much change over the last 10 years. And also 35 to 40, the 45 to 54-year-olds. So again, fantastic that we've seen the decrease in smoking prevalence among young adults. But it's time that I think, one of our theses says it's time to really focus on older adults now, since they've shown this stagnant smoking prevalence. So why, it begs the question, right? These graphs beg the question, why are we seeing this? Well, part of the answer has to do with quitting behavior. This is kind of old data that's from 2015, but it shows that past year quit attempts among adults over the age of 65 are lower than 18 to 24-year-olds. And same thing with the prevalence of interest in quitting, substantially lower than what we see in 18 to 24-year-olds compared to those ages 65 and older, and even compared to 45 to 64-year-olds. Is there another reason that prevalence rates are stagnant among older adults? We think so. We had this hypothesis that it may have something to do with e-cigarette use in our nation and what we've seen happen over the last 15 years with respect to the use of e-cigarettes. So if we go back to the NHIS data, yeah, we've seen these substantial decreases in smoking rates among 18 to 34-year-olds. Look what's happening to their e-cigarette use. It's higher than all the other age groups. It continues to go up. Look at what we see in 65 and older. We really see very minimal e-cigarette use, which really hasn't changed at all over the last 4 years. 35 to 49 and 50 to 64 are intermediate to those two. So some older adults have turned to vaping. This is a New York Times story from 2017, but really not that many have. And we can debate about whether that's a bad idea that they've switched or not. Here's a little more data on smoking and e-cigarette use, this time from PATH data. And again, looking through this lens, looking at younger versus older individuals. There's a lot going on in this slide. This analysis is basically just showing the progression or transitions from using various kinds of tobacco products between waves, wave one and following waves in the PATH data set. And so I'll just draw your attention to the upper left panel among 18 to 24-year-olds. Those who, maybe this is a good use of the laser pointer. Those who were exclusive cigarette users at wave one, what you can see is that 78% of them were still exclusively using cigarettes at a following wave. But 2% had transitioned to exclusive use of e-cigarettes, 7.3% to dual use, 13% to now being non-users. Let's compare that now to 55 plus. And what you see is that of those who are exclusively using cigarettes at wave one, in the following wave, close to 90% are still exclusively using cigarettes, which suggests not a lot of change in behavior among the older adults. And substantially smaller percent are converting to exclusive ends use, smaller percent to dual use, and of course, a smaller percent to non-current use. So this really just sort of highlights what's happening to cigarette smoking in these different age groups. Another way to look at this is with modeling data. So I want to now show just a little bit of some findings from Levy and colleagues. This is a paper in 2021. It'd be amazing to see an update of this. Maybe there's already one out there and I don't know about it, but this is a paper that they published in 2021, and they asked the question, can we estimate the effects of e-cigarettes on cigarette smoking behavior? Now, this is challenging to do. We can do small-scale clinical trials, but it's almost going to be impossible to definitively say at the population level what impact e-cigarette use has had on cigarette smoking. But this is an attempt to try to estimate that. So they took SimSmoke, which is their predictive model of smoking behavior, and they made projections of what they thought smoking rates would look like between 2012 and 2018 if e-cigarettes had never been introduced into the market. So they're using data before 2012 to say, assuming that there's no changes in the tobacco products landscape, but we do have, indoor smoking policies and taxation and other kinds of policies affecting smoking behavior. This is what we would see between 2012 and 2018. And then they contrasted that with what we've actually observed with regard to smoking rates between 2012 and 2018, which is essentially after e-cigarettes were introduced into the US market. And so the difference there is some estimate of the effects of e-cigarette use on smoking behavior. Now, there's all kinds of assumptions baked into this, and all kinds of, this is not an experiment per se, but it does give us some sense about how these things have balanced each other out between 2012 and 2018. And what they conclude is that during this period of 2012 to 2018, the implied e-cigarette related reductions in smoking prevalence were estimated to range from 43 to 53% for individuals 18 to 24 years old, 11 to 20% for individuals 25 to 44 years old. And at older ages, SimSmoke estimates were generally within confidence intervals of survey estimates, thus suggesting no difference. So to the eyes of their analysis, the introduction of e-cigarettes into the US market had really no appreciable impact on cigarette smoking among adults 45 years and older, which is consistent with what we also see in the prevalence data that we've looked at. Is this potentially problematic? We think so. I want to state there's no safe level of use of any tobacco products. At the same time, there's growing recognition and understanding that tobacco products exist along a continuum of risk. The FDA also recognizes this. They put out a statement in 2017 that nicotine, while highly addictive, is delivered through products that represent a continuum of risk and is most harmful when it's delivered through smoke particles and combusted cigarettes, less so when it is delivered through medicinal nicotine and products like e-cigarettes, snus, and other smokeless tobacco products. And so if we are living in a world in which older adults are continuing to smoke, but not availing themselves of these lower risk tobacco products and switching to them completely, then we're faced with a situation where they're not benefiting as much as younger people from the presence of these products in the tobacco product marketplace. All right. I know that when I have trouble talking, it's time for me to stop. So an intermediate conclusion and a question. So we think that e-cigarettes are likely responsible, or certainly in some way responsible, for declines in smoking in all age groups except older adults. And switching to e-cigarette use is associated with reduced carcinogen and toxicant exposure. So the question begs the question, what is keeping older adults from quitting smoking? And for those who cannot quit, what is keeping them from switching to the use of lower risk tobacco products, including e-cigarettes? And so this has become a significant research question for us, and one that I've been very excited to work with Dana Olin. We first started working together during her first year of medical school, and this was a priority population that we identified relatively early on, and we've been focused on generating both a database of findings, making clear the relationship between age and product perceptions and product use, but also starting to develop a conceptual framework. So in 2023, we published a conceptual model to understand, based on the literature, the factors that may affect smoking cessation among older adults and switching to non-combusted products, and then a series of analyses of path data, which Dana will present, providing some additional empirical data on these for this model. So at this point, I am going to let Dana take the reins and present our recent work in this area.
Okay, thanks so much, Joe. Um, so I'll start out by introducing the conceptual model that we just talked about. Next slide, please. Here. So this is a model we created of completely switching from combustible cigarettes to e-cigarettes among older adults. And to develop our model, we looked into the literature on tobacco use and aging and trying to find reasons why older adults may continue to smoke, have trouble quitting, or have trouble switching to e-cigarettes. Based on that, we adopted a health belief model to generate hypotheses about why older adults might not be switching from combustible cigarettes to e-cigarettes, which we believe is a representation of reduced harm. Health belief models have been used to explain how various beliefs, attitudes, or perceptions serve as barriers or facilitators to a broad range of health behaviors, such as diet or exercise, and here this smoking or switching from smoking to e-cigarette use. And so this is the model that our team conceptualized. First, we have one type of misperception is the misperception that nicotine is the main cancer-causing agent in cigarettes, or the main the main agent causing damage in general in cigarettes. This might lead older adults or others to not switch from cigarettes to e-cigarettes, since e-cigarettes also contain nicotine. But as we'll talk about afterwards, this is really a misperception about nicotine. There are other chemicals that are actually harmful in cigarettes. And then the next type of misperception is about the risk of continued combustible cigarette use. And this one is particularly important for this population of older adults, because older adults might think to themselves that at a certain point that the damage is already done from smoking, or they might ask themselves, what's the use in quitting now if I smoke my whole life? It's still okay. So this is an important misperception that might be unique to older adults. The next type of misperception is about the relative risk of tobacco or nicotine-containing products, namely the belief that cigarettes are less harmful than e-cigarettes, when it's really the other way around, where e-cigarettes represent reduced harm compared to combustible cigarettes. And lastly, we didn't find much literature on this, but we hypothesized that there may be specific benefits of switching to e-cigarettes among older adults who smoke, and some of these benefits might include not smelling like smoke, or having improved health, increased longevity to spend more time with kids and grandkids, for instance. So to investigate these questions, we use the population assessment of tobacco and health data set, or PATH, as Joe's already mentioned a few times. And this is a nationally representative longitudinal cohort in the U.S. We used cross-sectional data for this one from 2018 to 2019. And we restricted all of our analyses to adults who had established cigarette use, and this was about 8,000 people. We calculated the weighted prevalence of various harm perceptions or normative beliefs that came from our conceptual model for each of 6 age groups, and used logistic regression to model each harm perception or normative belief based on age and a number of other variables. To start out with the sample demographics, there's nothing too much to discuss here other than that this was largely nationally representative. And I'll point out that nearly a third of the sample was greater than or equal to the age of 55. Now, we started our investigation by first examining the association between harm perceptions and age. And previous research has demonstrated a relationship between harm perceptions of tobacco products and their subsequent use. For instance, the association between the relative risk of cigarette and e-cigarettes and transitions from smoking to later exclusively using e-cigarettes. But these relationships hadn't been previously studied in the older adult population specifically, so we wondered how they might fit into all of this. We also mentioned earlier that nicotine misperceptions. So there's this misperception that nicotine causes cancer, which directly contradicts evidence from the 2014 Surgeon General's report on health consequences of smoking, which reports that after decades of research, we know that toxicants other than nicotine are primarily responsible for smoking-related diseases, and there's no direct causal link between nicotine and cancer. So we started by looking at this misperception that nicotine causes cancer, again, among US adults who smoke, using young adults ages 18 to 24 as the reference group. We found that people over the age of 55 were more than twice as likely to report that nicotine causes cancer, and people over the age of 35 in general were significantly more likely to have this misperception compared to young adults 18 to 24. And not only do older adults who smoke have this misperception of the harms of nicotine, but also over 80% of physicians nationwide, when surveyed, had this misperception and other misperceptions that conflate nicotine's role in addiction with harms caused by the combusted toxicants in cigarettes. So we also have misperceptions about nicotine-containing products themselves, in addition to that misperception about nicotine. And the first one, well, this is actually a harm perception that is accurate, and using cigarettes is very or extremely harmful, which we want people to buy in and believe that and understand that. However, even though around 70% of people over the age of 65 indicated that smoking cigarettes was very or extremely harmful, they were still significantly less likely to report this than the young adults aged 18 to 20. One of the main reasons older adults might have decreased harm perceptions of cigarettes is that they experienced a time period in their lives when smoking was normalized or even encouraged on places like airplanes. They have a long history of smoking and being around smoking. And older adults also might have the thought that they wouldn't have made it to this old age if smoking were harmful. Now, switching from cigarettes to e-cigarettes, looking at the misperception that e-cigarettes are extremely harmful, we found that, as hypothesized, older adults were more likely to believe that e-cigarettes are harmful, and this was true for all of the age groups over the age of 35 compared to 18 to 23-year-olds. This isn't surprising given that e-cigarette use has been glamorized in recent years, especially among adolescents and young adults via social media. On the other hand, older adults might be more affected by media reports and campaigns on the dangers of e-cigarettes, a lot of which were around the time of E-Valley and might no longer be relevant. Now, combining these two harm perceptions, when asked about the relative harm of e-cigarettes and cigarettes, adults who smoke over the age of 35 were significantly more likely than young adults to report e-cigarettes as more harmful or about the same as smoking cigarettes, which again is a misperception. So now I'll present this. This study is from a group at Rutgers that followed up on our work with a longitudinal perspective using PATH. And I know this slide is very busy, but I'll just walk you through a couple of things. So the column on the right is for older adults, and they use a cutoff of 45 plus. So I'm sorry to break that to some people in the audience that you might be considered older adults by this research paper. This is looking at how harm perceptions in one wave of PATH influence cigarette smoking or switching behavior the next wave. So we see first that having a high absolute harm perception of cigarettes was associated with decreased odds of current cigarette smoking follow-up among older adults, which is good to see. And we also see that high harm perceptions of cigarettes, as well as high harm perceptions of e-cigarettes, were associated with increased intention to quit smoking. So these two models so far are showing that we have relationships between harm perceptions of smoking and e-cigarettes in a way that could be helpful to older adults. However, when looking at the harm perceptions and their potential association with later switching from cigarettes to e-cigarettes, there was nothing significant here. So I think one of the main takeaways from this study is that messaging or health communications could be a powerful tool to really reinforce the correct perceptions and beliefs about e-cigarettes and cigarettes to older adults, so that they will have healthier smoking or quitting behavior or switching e-cigarettes follow-up, which is what we want to see. And some of that might require reinforcing the relative harms of cigarettes and e-cigarettes. Now, switching gears a little bit from the harm perceptions, normative beliefs also impact tobacco use. We've learned this especially from the literature on e-cigarette use among youth and adolescents, and how important those social networks are and peer behavior. We also see that with adults, where individuals might be more likely to use e-cigarettes if their family or friends support e-cigarettes as a tool for smoking cessation. There's limited existing literature on this topic among older adults, but thus far, the data suggests that older adults are less likely to report that they have close friends who use e-cigarettes. And to contextualize some of these normative beliefs in older adults, it's worth noting that in addition to that time period in their lives of normalized smoking, like on planes that I mentioned earlier, they later experienced the villainization of smoking after the 1964 Surgeon General's report, and subsequently experienced decades of increasing public policy measures intended to curb smoking. This might explain the finding that people who smoke over the age of 45 were more likely than the young adults aged 18 to 24 to have the belief that most people in general disapprove of smoking cigarettes. And then also, as expected, given the harm perception about e-cigarettes that we talked about and cultural influences around e-cigarette use that differ by age, we found that older age was associated with the belief that most people disapprove of e-cigarette use. All age groups over 25 were more likely to endorse this compared to young adults 18 to 24, but would like to point out that adults over the age of 55 were more than twice as likely to endorse this belief. And then finally, to end with some good news that's especially relevant to anyone who works with patients clinically, respondents were asked if they'd been to see a healthcare provider in the last 12 months, and if so, if they were advised to quit smoking. And we found that adults over the age of 45 were more than twice as likely as young adults 18 to 24 to report that they had received advice to quit smoking. In addition, when looking at moderation effects, we further observed that receiving advice to quit was more strongly associated with attempts to quit among adults over the age of 55 versus under 55. So to start summarizing the relationship between tobacco use and age, older adults fulfill all criteria of tobacco use disparities groups as defined by Williams and colleagues in the American Journal of Public Health. The first criterion is that the smoking prevalence is stagnant. As Joe presented at the beginning, smoking prevalence among older adults has not changed over the past decade, and this is likely due to a combination of both stagnant quit rates and low uptake of e-cigarettes. Additionally, older adults have increased tobacco-related disease burden. As I mentioned, there's a low quit prevalence among older adults, and so these are verbatim the criteria for tobacco use disparities groups among the paper at Williams. And the last one is that they've been targeted by the tobacco industry. So I haven't talked about that in this talk yet, but older adults actually have been targeted by the tobacco industry, much like other tobacco use disparities groups. And for this specific population, I'll give the example that tobacco companies used to visit nursing homes and give out free sample cigarettes or coupons to really try to encourage older adults to smoke. Nevertheless, older adults are not recognized as a tobacco use disparities group by federal agencies such as the FDA, CDC, or NCI. So research funding is not prioritized as much as it should be for this population. In conclusion, older adults who smoke should be encouraged to quit and supported in their attempts to quit. As we've demonstrated, older adults have unique perceptions and beliefs that might serve as barriers to quitting smoking. And when that's not possible, to switch from cigarettes to e-cigarettes. Some of those perceptions include the fact that there are greater harms if e-cigarettes perceived among older adults, especially compared to cigarettes, or that older adults are more likely to believe people disapprove of e-cigarette use. And lastly, for future directions, we plan to work towards advocating that government agencies recognize older adults as a tobacco use disparities group. We'll do this by continuing to publish this area and speaking to program at these agencies. What is it that will increase research funding towards older adults who smoke? Additionally, we recommend focusing research on understanding the barriers and facilitators to quitting smoking among older adults. We also suggest tailoring public health and clinical cessation programs towards the specific and unique needs of older adults. And lastly, our research indicates that better messaging strategies are needed to communicate accurate information about the continuum of risk of nicotine-containing products and to dispel misperceptions about these products to older adults. So thank you so much, everyone, for listening to our presentation. Thanks, Joe, for the mentorship and work with me on these projects, as well as our other collaborators, including Dana Carroll. And so grateful to be here today with one of our favorite institutions and to share work with all of you. So thank you. Feel free to reach out to us separately, and we can take a few questions now as well, I believe.
Yeah, thanks so much, Dana and Joe, for a wonderful presentation and for not leaving behind a population that has been by public health for what seems like a very long time. So, folks, please enter your questions in the chat. Alexandra, I know did you want to ask a question first, and then I can go while other folks put their thoughts into the chat?
Yeah, thank you. This was wonderful. I've learned a lot. And one thought that I have is maybe I would be very interested to hear your thoughts and maybe speculation. You've mentioned that it's obvious that these misconceptions persist, and you've touched on some of the factors like normalization of smoking during that adult lives, and then the harmfulness attributed to e-cigarettes, especially during the Valley crisis that happened. I was wondering if you can talk about some other factors, like social factors, cultural factors that are driving this misconception in these population groups, and what could be some potential intervention to kind of demystify this misconception and bring this population closer to cessation. Thank you.
Yeah, that's a really great question. Thank you for posing it. You know, I think with respect to the first piece, we're really just starting to scratch the surface. So many of the analyses and research that's been conducted to date, you know, you take path analyses, for instance, when they've looked at age as a factor and not just simply a nuisance variable, they'll look at, you know, they might look at 18 to 24-year-olds and then 25 and older, right? And we've actually even done the same thing in some of our analyses of CNIC data. So we're just now starting to appreciate, I think, that tobacco use patterns vary across the lifespan, that perceptions vary across the lifespan. And so there's a couple of points I want to make about that. One is, age is also conflated with, history, right? So how do I want to say that? Like a 35-year-old in 1980 is going to be very different than a 35-year-old in 2024, right? So it does make it really interesting to think about how these cultural factors and histories of how tobacco use is portrayed, how tobacco companies have marketed it over time, intersects with one's age. It's very hard to untangle those things, though, at the same time, right? So I wanted to say that. The other piece is that we haven't started to look at, in a very nuanced way, intersectionality. So, just as we would with any other group, older adults are a heterogeneous population. Older adults who live in rural areas are going to be maybe different in some important ways from older adults who live in urban places. Race, ethnicity, sex and gender, all of these things may interact in meaningful ways with age. And we really haven't started to look at that, but we should. And then in terms of what we do about it, I think Dana did a nice job of summarizing some potential future directions. We're working right now on efforts to secure funding to flesh out the model in more detail. The model that Dana presented, we sort of scoured the literature to build that model, and it didn't take very long. There wasn't a whole lot of literature to build from, because we just haven't been asking these kinds of questions of older adults. And so part of what we want to do is we want to collect the data that will allow us to build out a more accurate model, start to understand some of these nuances of, say, middle-aged versus older-aged adults, start to look at cultural influences, build the model out so that it's more robust. And then the second part is to use what we learn from older adults who use tobacco products to develop corrective messages and communications to try to change some of the beliefs and misperceptions around tobacco products. And then once we've developed those messages, I know I'm outlining like this is like aims 1, 2, and 3, right? After we develop the messages, then they can be used in a broad range of contexts, right? I mean, they could be used to help promote health behaviors like using quit lines. They could be used in the context of smoking cessation interventions. They could be used in the context of patient-provider communication. So those are the kinds of things that we're thinking about.
Thank you. Thanks, Joe. That was really thorough. I have a couple questions and maybe comments too. I can go next, and then all of the folks in the audience, don't be shy. Feel free to put your questions in the chat. So really great presentation. I think this can kind of go toward you, Dana. So it seems like you guys have really dug into the nuance of what we know that differs between age groups, which makes a lot of sense. And I'm wondering if you've done or plan to do as a next look at the data is within the older adults. So who is switching to e-cigarettes? I'm sure there's some. And what predicts belonging to that group? In the same vein, I think looking at a comparator of, as I believe you restricted to current smokers. I mean, who are the current e-cigarette users and how do they differ? And so I think there's a lot of ways to continue to slice the data. I'm just curious if you've looked at it further.
Yeah, that's a really good question slash comment. And I mean, I think as with any priority population, when you want to get more nitty-gritty details, it can get really difficult because of the sample sizes being so small. So for instance,
Sure.
looking at the number of older adults who use e-cigarettes, that's like an extremely low percentage. We definitely do have plans to have further parse out the different phenotypes of older adults who smoke or who don't smoke or use e-cigarettes. And so we're looking towards potentially checking out other data sources like the health and retirement study or studies that focus on older adults to better answer some of those questions, which can also answer some of what Joe brought up about intersection.
Yeah. Yeah. Great. I look forward to seeing that work continue. The other thought I had is, and it makes sense, all of your work now has focused on really like e-cigarettes as a potential to harm reduction. I just wonder about like these oral nicotine products and smokeless tobacco. And it almost seems like this would be really ripe for qualitative work. Like, what is it about the e-cigarettes? I mean, I don't like to charge anything, and I'm not in the older adult group yet. And I wonder if the idea of charging and batteries, I mean, or what is it? So I'm just curious if you guys have thought about some qualitative data to kind of dig and contextualize your quantitative data.
Yeah, no, that's a really good point also. And I think a lot of the work on oral nicotine products has been certainly focused on youth and adolescents. So I've seen if there are older adults using those, and if so, why or why not, I think would definitely be interesting to look at that qualitatively as well. I think finally surveys or like national surveys are starting to ask about that. So
Sure.
As a first step, that could possibly help us at least to quantify how many adults are using different types of nicotine-containing products, and then putting up and that focus groups and really qualitative work.
Yeah, seems really ripe for research. All right, I'll have one more comment, and then it looks like Emily put a question. So I was really reflecting on how, older adults have been forgotten, and your suggestion around, or maybe just the comment that they're not considered a health disparity group. It seems, I think there's kind of different ways to think about the word health disparity, and the work by Braveman, which is cited a lot, really says that differences in health to be due to a health disparity have to be really linked to social disadvantage and these social determinants of health. And so it's just something that maybe there could be a commentary there, or, a perspective piece to advocate or explain why, from that lens, this group has certain barriers, social determinants of health that would place them kind of in this health disparity category, like some of the other groups that I think we typically think of with health disparities. So just food for thought. Okay. And Emily said, great presentation. I have a question related to the misperception that nicotine causes harm. This is something I've been grappling with for a while, particularly in the context of a reduced nicotine standard. How do we distinguish between nicotine directly causing harm and the fact that the addictive nature of nicotine is the reason why most people use tobacco products, and therefore the reason they end up experiencing harm? Does it matter for this population? Thank you.
Yeah, thanks for that question, Emily. That's a really good point, and definitely something that is a big struggle when thinking about communicating a nicotine reduction standard. Yeah, I guess that nicotine doesn't directly, and it's really the point is that nicotine doesn't directly cause the harm. It's that it makes you keep smoking, and then the harm comes from the other toxicants in there. But it's really complicated to understand, as we saw, like even most physicians don't understand that. So I think one of the reasons this is really important for older adults is not only to the point about the potential that this could be a factor impeding them from switching to e-cigarettes, but also this could even impede them from using nicotine replacement therapy other proven strategies that could be helping them quit smoking. So that's what I would say from that. In terms of, it doesn't matter for this population or the role that it plays, but would love to see the messages that you develop for kind of communicating nicotine reduction standard, and then I'm sure some of those may also be really helpful for communicating about the nicotine harms to older adults.
Awesome. Thank you. Yeah, great question. A lot to unpack there. What other questions do folks have? We have a couple minutes.
While we're waiting for another question to come in, I'll also say that, one thing in looking at the literature, we've had a little bit of a difficult time identifying is research that looks at the effects of late life quitting on health outcomes. So there is a lot of course, right? There's a lot of data that smokers don't live as long as people who smoke don't live as long as people who do not smoke. And that smoking is related to a whole raft of medical problems. There's really not a lot of data out there on how does quitting in your 70s or 80s impact both morbidity and mortality. So we're also starting to think about ways that we can leverage existing data sets to start looking at those kinds of questions, with the idea being that we want to overcome this belief that older adults may have, and there's some qualitative data to suggest this, that as Dana was saying earlier, what's the point? I've made it 80 years as a smoker. Why should I quit now? The damage is done. So I just wanted to offer that as another area that we're starting to look at. Not that, telling an 80-year-old who smokes, if you quit, you'd be healthier, is necessarily going to motivate them to quit. We know that doesn't always get us very far with people who smoke of any age. But it's worth noting that there's just a dearth of literature out there on that.
Yeah, that's fascinating. I think even if it's not for their own health, I think what Dana mentioned, like younger generations are seeing their grandchildren grow up, which makes a lot of sense.
Mm-hmm.
We got a comment. I'll let you guys, sometimes reading on your own is better. So maybe folks can read and then respond to the question.
Yeah. Did I miss one up above?
Nope, that was Emily.
Yeah. So Alex, yeah, thank you. Yeah, I think that's a really interesting one to explore too. And as Dana was talking, I was thinking about social determinants of health. And I don't know that if anyone has explored, most people over the age of 65 are on a fixed income, right? Looking at the impact of having to expend income on tobacco products and the effects of that, not only on their health with respect to the effects of tobacco use, but that may have other impacts on their health in terms of they're eating fresh fruits and vegetables, for instance, or engaging in other health behaviors. So I think that's a really interesting question. I think it is. I'd love to hear your thoughts, Dana. I mean, does that get at sort of what you were thinking about in terms of Braidman's look at social determinants of health also?
Yeah, exactly. I think hitting it on the head with the financial stability and income is really, really interesting. I invite Alex just to unmute and talk. So now he says there's probably some room for behavioral economic research. Yes, demand elasticity, tobacco purchasing behavior on people with fixed incomes. Yeah, that's a really interesting. I don't know.
I haven't read a lot of the literature.
I don't know if it's been done.
Yeah, right.
I'd be curious to find out. I decided to unmute.
Yeah, no, thank you. And you know, it's probably worth an email to folks who do that work to ask them if they've looked at it. I can't remember in any of the taxation research that I've read, there's been a look at anyone's looked at age or looked at I would guess income level is probably something people look at, but maybe not look at age.
Okay, great. I think we have a minute for one more question. I saw Arena.
I think Dana was
Green?
yep. Dana, did you follow up on that real quick?
No, nothing too much. I was just going to say that I thought that was really interesting, and I haven't seen anything in that area yet.
Yeah, hi Joe, very nice seeing you. Thank you for really great presentation. And I guess I'm thinking about, some research that we have done on the relationship between product itself and risk perceptions and other, harmful exposures. So I'm wondering, what do older adults smoke? Is there any data on better understanding if there are certain cigarette brand and product characteristic preferences and how those characteristics could potentially affect perceptions of risk in older adults specifically?
Yeah, that's a great question. Dana Rubenstein, have you looked at that in any of our analyses?
No, I haven't looked at anything related to brand, so yeah, I'd be interested to see that as well in adults.
Yeah, we see some interesting associations even when, almost probably a lot of it is subconsciously, that certain population subgroups, people who smoke and have certain patterns or certain belief, they gravitate to cigarettes with specific characteristics. And we don't know, it's kind of chicken and egg question, do they select, or is there something about brands that affects those perceptions and selections? So anyway, that would be something to take a look. We have a database of cigarette brands that could potentially be tapped into to ask these questions.
Nice. That's cool. Great.
Great. Thanks, everyone. I thought that was a really lively Q&A. And Joe, Dana, thank you so much for joining us this first seminar back. Really appreciate the time and the effort that you took to be here today.
Thank you for having us. This was excellent.
Great. Thanks, everyone. Have a wonderful day.